This is the first video in the cardiology series for the CCRN review practice questions. Feel free to pause after each question to give yourself time to think about your answer. Question number 1. A patient is 42 hours post-aortic valve replacement. Which of the following is a priority for this patient? Diuretic therapy, prevent thrombus, stabilize blood pressure, or prophylactic antibiotics? And the answer is B, prevent thrombus. The formation of a clot on a valve replacement remains a major complication, especially a valve that's mechanical. So therefore, anticoagulation will be required. Fluid overload, labile blood pressure, and infection are all possible. However, thrombus formation and the subsequent stroke remain the highest priority in preventing post-op complications. Okay, for our next question, question number 2. Which of the following is indicated during the embolization of an AV malformation procedure? Heparin, fluids, fibrinolytic therapy, or phenytoin, also known as dilantin. And if you don't know, the AV malformation is the tangled web, essentially, of blood vessels in your brain that's typically formed during birth. So the answer is A, heparin. This is because heparin is indicated to prevent clot formation during the surgery. Fibrinolytic therapy, phenytoin, and fluids are not indicated. However, they might be required post-op, depending on the prognosis of the patient. Okay, question number 3. The patient has an acute right ventricular infarction and subsequent right ventricular failure. Which of the following is an indication that this patient's condition has improved? A, the pulmonary artery diastolic has increased. B, the right ventricular pressure has increased. The right atrium pressure has decreased. Or the pulmonary artery occlusion pressure has decreased. It's also known as the wedge pressure. So the answer is C, the right atrium pressure has decreased. And this is because the right atrium pressures are elevated during right ventricular failure due to right ventricular infarction, and a decrease is evidence that the treatment is effective. The wedge pressure is the pressure of the left heart. It is often already low in the RV infarction due to the preload decreasing on the left side of the heart. A further decrease is not warranted. And for the next question, question 4. A patient complains of chest pain with deep inspiration, which becomes worse while lying supine. You auscultate a friction rub and note sinus tachycardia on the bedside monitor. Which of the following would you expect to find on a 12-lead ECG? ST depression in RV2, RV3, ST elevation in 2-3 and AVF leads, ST depression in V1 to V4 leads, these are the septal leads, or ST elevation in 2-3 AVF and V2 to V5. And the answer is D, ST elevation in 2-3 AVF and V2 to V5 leads. This is global ST elevation representing pericarditis in the setting of the friction rub auscultated. The second answer is seen with acute inferior wall STEMI. Answer C is seen with anterior wall ischemia or the non-STEMI. And answer A is associated with right ventricular ischemia or infarction. Okay, for the next question, question number 5, which of the following patients is most likely to experience a heart block? A cardiac transplant patient, a patient that is status post-CABG, a patient who has undergone a mitral valve repair, or a patient with a repaired ventricular septal defect? And that answer is C, a patient who has undergone a mitral valve repair. The reason for that is the aortic tricuspid and mitral valves are anatomically located near the conduction pathways of the heart. Therefore, the patient who has undergone a mitral valve repair may develop a heart block post-op, which is thought to be related to a local effect on the conduction pathways. Question number 6. A large 32 mm V wave appears on the pulmonary artery occlusion pressure tracing of unstable patient after an extensive inferior wall myocardial infarction. This finding is consistent with congestive heart failure, cardiogenic shock, pericarditis, or mitral valve regurgitation. And the answer is D, mitral valve regurgitation. This is because large V waves are created by regurgitant flow backward into the left atrium during left ventricular systole. The other choices do not cause backflow of blood, and therefore the resulting V wave enlargement. Moving on to the next question. After receiving a diagnostic right heart catheterization and a percutaneous coronary intervention, otherwise known as a PCI, the cardiologist informs you that the patient has had an elevated left ventricular filling pressure and, along with that, a low cardiac output. Which therapy would be beneficial for the patient? Left ventricular afterload reduction, heart rate reduction, left ventricular preload elevation, or negative inotropic therapy? And the answer is A, left ventricular afterload reduction. This is because an elevated left ventricle filling pressure and a decreased cardiac output would benefit from a decreased systemic vascular resistance, otherwise known as LV afterload. A vasodilating drug such as ACE inhibitor or intra-aortic balloon therapy would provide the afterload reduction. Decreasing the heart rate will help diastolic filling, however, will not reduce the SVR or the LV afterload. Elevating the LV preload or using negative inotropic therapy would make the problem much worse. Question number 8. When there is a drop in the cardiac output, which of the following is a normal compensatory response? A. Increased oxygen extraction. B. Decreased oxygen consumption. A decreased heart rate, or increased oxygen delivery. And the answer is increased oxygen extraction. Oxygen utilization is about 300 milliliters per minute, whereas oxygen delivery is approximately 1,000 milliliters per minute. If the cardiac output decreases, myocardial extraction of the oxygen will increase, leading to an increase in heart rate. A drop in oxygen consumption and a decrease in heart rate do not occur with a decrease in cardiac output. If the cardiac output drops, oxygen delivery will decrease, not increase. Our next question. A 54-year-old male is admitted to the ICU for ST elevation in the V2, V3, and V4 leads. Intravenous thrombolytic therapy was started in the emergency department. Indications of a successful reperfusion would include all of the following except pain cessation, absence of troponin elevation, reversal of the ST segment elevation with a return to baseline, or short runs of ventricular tachycardia. And the answer is absence of troponin elevation. This is because the damage essentially has already been done. The patient is having an anterior wall myocardial infarction, so even with a reperfusion in a timely manner, the cardiac biomarkers such as troponin will be elevated. When the occluded artery opens, however, choices A, C, and D will occur. And to finish up this video in the cardiology series, you are caring for a patient after she has undergone a coronary artery bypass graft surgery. You should anticipate a possible drop in blood pressure during rewarming, strip the chest tubes hourly to maintain patency, maintain the blood sugar levels at 150 to 200 milligrams per deciliter with an insulin infusion, or maintain serum potassium at 3 to 4 milliequivalents per deciliter to prevent arrhythmias. And the answer is A, anticipate a possible drop in blood pressure during rewarming of the patient. This is because as the patient's temperature rises, vasoconstriction that was present at lower temperatures decreases, potentially causing a drop in the patient's blood pressure. For the CCRN, chest tubes should never be stripped. A blood sugar of 150 to 200 milligrams per deciliter is too high for a post-op CABG patient, and serum potassium needs to be closer to 4.0 milliequivalents per deciliter, as 3.0 is too low. Thank you for watching this video in this cardiology series. I hope you learned as much as you can. If you like this video, please check out the next video in the cardiology CCRN test series, and have a good day.